So instability is an issue that's very common in the shoulder, affects a lot of age ranges, and tends to be a problem that doesn't solve itself. Instability in the shoulder is very, very common. Some people feel that it's the most common cause of pain in younger patients, meaning patients in their 20s and 30s, let's say. Certainly it's more common than things like arthritis or other issues in that age range. So someone comes in, they're having pain in their shoulder and they're 22. My first thought is it's probably instability, and we'll talk about what that is. Some people know it's instability, meaning they come in because they dislocated their shoulder. They fell skiing or on the soccer field, shoulder popped out, somebody had to pop it back in. That's fairly obvious. Sometimes it's not quite as obvious of that. There are elements of instability that can be much more subtle. In terms of what is instability in the first place, well, we have to talk a little bit about the anatomy of the shoulder. And in simplified terms, I say that the shoulder is a ball and socket joint, and I use my hands as an example. Your arm bone comes up and ends in a ball, and it meets the socket of the shoulder, the socket being very similar to my hand. The socket is quite shallow. It's not flat, but it's pretty shallow. And because of that, the shoulder turns out to be the most mobile joint in the human body. That's an interesting piece of information. I like that idea. So as the most mobile joint, that's great, but it also is one of the most unstable joints at the same time. It's the most commonly dislocated joint in the human body for that reason. So with force, like a fall of any sort, you can have the ball come completely out of the socket, and that's what a shoulder dislocation is. Sometimes that occurs, and in an instant it comes right back in. The person dislocates their shoulder, and it goes back in the socket, or reduces, as we say, all on its own in a fraction of a second, to where the person isn't even sure what happened. They fell, it hurt a lot, and then it was just something happened, it got better, but it's sore. Other folks know it pretty clearly. It's out, doesn't feel right, it's completely out. They had to go to the emergency room, they had to be sedated, have it put back in as a procedure. But both of those things mount to the same issue, which is now the shoulder is unstable. And unstable means it's been out once, and if it has been out once, it is very likely to keep coming out repeatedly. So recurrent instability, meaning additional dislocation events after the first time, are very, very common. It's more common the younger the person, so there's an age-related aspect to this. If you're 20 and it happens, you have a dislocation, you're almost certain, more than 99%, in fact, likely to have more repeated dislocations. If you're 40 when it happens for the first time, it's much less likely, but still about a third of people will have recurrent instability. So instability is an issue that's very common in the shoulder, affects a lot of age ranges, and tends to be a problem that doesn't solve itself. Occasionally we can see someone, evaluate them, recognize that it's the first time and the instability is relatively a low level, and it can be treated initially with physical therapy, strengthening of the muscles around the shoulder, rotator cuff, and other musculature around the shoulder blade to try and add stability to the shoulder. But frequently, instability is a recurrent problem that needs surgical repair to essentially tighten the shoulder or repair it in a way that prevents that recurrent dislocation or instability. One of the concerns with recurrent instability, if left unchecked, is not that it's just inconvenient, which it certainly is. Having your shoulder come out all the time and have to go to the emergency room all the time is inconvenient, not to mention expensive, but disruptive to your life and work. But more than that, we now know from some longer-term studies that recurrent instability can put people at risk for arthritis in their shoulder later in life. And so certainly dislocating the joint over and over again is just simply not good for it. So we don't want to let that go unchecked. People that have instability, again, sometimes they know it. Their shoulder comes out, they have to put it back in or get someone else to put it back in. Sometimes they're not really aware. It's sliding around, or subluxing is the term that we use. People have heard of subluxation. That means that the shoulder has come partially out, but not all the way, and then it goes back in on its own. But each of those events essentially are bad for the shoulder. They cause pain. And these are all problems that are solvable most of the time with surgery to tighten the ligaments of the shoulder to allow the shoulder to go back to its normal, stable state. For some patients, it's quite obvious. They're dislocating their shoulder. They know it's dislocated. In fact, it's stuck out in a repeated way. They're going to the emergency room over and over again to have their shoulder put back in. It's quite obvious. But for many patients, it's actually not that obvious. Either the shoulder is not coming out all the way, or it feels funny to them or painful. What I sometimes say is that shoulder pain, really at any age, but particularly in younger patients, it's not normal to have shoulder pain. And shoulder pain that goes on for, let's say, 3 months after some event, an injury, or even just overuse, really should be evaluated. You don't have to rush in the next day when your shoulder's sore, but if your shoulder hurts and it's been 3 months, I think that's the time to get it looked at. And by looked at, I mean a physical exam. For many people, particularly with rather subtle instability, where the shoulder maybe hasn't come out completely or hasn't been recurrently unstable, many tests, including x-rays, can look completely normal. And it's only with a really careful and skilled physical exam that you can figure out that it's truly instability and not a different problem in the shoulder. Instability is most easily diagnosed on physical exam, not by testing or imaging. And so I think 3 months is a good time frame for someone who's having ongoing pain that's not resolving. At 3 months, it's no longer just a sprain or a strain, it's something else that's going on, and that really should be looked at that point. Instability is a solvable problem. We have good solutions for it, but it's not something that typically solves itself. So in terms of talking about treatment for instability, there are many patients that can be treated without surgery. With a good physical therapy program and some attention to detail, we can improve stability in shoulders, particularly subtle, sometimes referred to as multi-directional instability or micro instability, or different words that describe patients that have pain because of instability but aren't really dislocating. And those are often things that we can solve with physical therapy. For patients that have had recurrent dislocations, those are typically not things that are solvable without surgery. You need to have repair of damaged ligaments to really get that better. Ignoring that or avoiding it can cause long-term damage to the joint surfaces. Each time there's a dislocation, there's a potential for damage leading to arthritis. So we don't really want to wait for that to happen. In terms of the surgical repair, again, it's an area where the techniques and the technology we use has evolved quite a lot, even in the last 5 years, where the sutures, the anchors, the systems we use to do the repairs are much more precise, they're much stronger, and that gives us a more reproducible repair done in a way that is minimally invasive, and that really gets people back and recovered much more quickly than it was in the past, with much less pain and I think a better outcome and better results.